My name is Johanna Moore. I'm an emergency physician and a CPR researcher just down the road at Hennepin County Medical Center. I did my emergency medicine residency at Hennepin, graduated in 2010, did a clinical research fellowship, and did my MS degree over at the university. And I've been doing clinical research, animal research since that time, and happy to answer any questions throughout the talk here. It doesn't have to be extraordinarily formal. Emergency medicine docs are not that formal, as you might know, so that's kind of how I operate. We're going to talk about head-up CPR, which is a very novel, promising therapy for cardiac arrest, and our laboratory group is kind of the premier group, if I do say so myself, in the world on this topic. So please, interrupt if you have questions. It's something that's highly, the resuscitation community is highly interested, and it's getting a lot of momentum, so it's pretty cool to talk about. I don't have any conflicts of interest from industry. I am a co-PI on an NIH NHLBI SBIR grant that was awarded to our group. So we'll jump right in here. So God forbid you're in a cardiac arrest yourself. This is your brain on CPR. So which curve do you want? So let's look at what I'm going to use my mouse here for our online audience. So let's look at what our graph says here. So on our y-axis, we have cerebral perfusion pressure. So Monday morning, let's go back to basics. Is this a good thing to have cerebral perfusion pressure or a bad thing? This is a good thing, yeah. We want to have that. So then this is time in minutes. This is time of resuscitation. So this is our baseline value, 2, 7, 12, 17, 22 minutes. So which one do we want? What color? A blue, yeah. This is not rocket science, not even neurosurgery. Let me go for it. Okay. So what are we looking at here? We're looking at a pig study. So the top line is active compression, decompression, CPR with an impedance threshold device in the head-up position. And so that's giving us values that are around 2/3 to 3/4 of our baseline cerebral perfusion pressure, which is pretty amazing in my opinion. So the red line is active compression, decompression, CPR with an impedance threshold device in the supine or flat position. And below that, we have conventional CPR or manual CPR at a rate of 100. So the green line is head-up CPR, and then the purple is conventional flat CPR. So you'll notice cerebral perfusion pressure there at 22 minutes, which is around an average resuscitation time for people. That value is negative. That's highly undesirable, and it's actually the standard of care in this country and in the world right now. So we've got our work cut out for us. This is a pig study that we did several years ago now, and these are the curves generated from that. So this is an actual CPR study from an animal model. Yeah.
The pig was in the side, on the side, the pig was supine, was it on the back or on the side?
Yeah, it's on its back. Yes, which is not a natural position for pigs.
Yeah.
Which is, this is an animal model, so it's.
Yeah.
But this is how we do that. Yeah, yeah. So obviously several limitations. So just to hammer home our take-home points, and I'll take you through these points throughout the talk here. So our animal studies have shown that head-up CPR compared to flat CPR increases your cerebral perfusion pressure, it increases cerebral blood flow, increases coronary perfusion pressure, and it decreases intracranial pressure. We've replicated some of our just basic hemodynamics in the human cadaver model, which we'll talk about also. And we've also shown that increases cerebral perfusion pressure and decreases intracranial pressure. And then preliminary data has shown that our head-up CPR is used as part of a bundle of care where a bunch of things were changed in a EMS system in Florida has resulted in increased survival to hospital admission rates. So why do we need to improve CPR in the first place? Because we suck at it, right? So, yes. So national survival rates after cardiac arrest remain dismal, right? So this is out of circulation several years ago. So we have on the left, this is a graph just looking at overall survival. of course, if you or I had a cardiac arrest, we'd want to be over here. We'd want to survive with functional neurologic recovery, right? So a CPC, cerebral performance category of 1 or 2 is considered functional. As you can see, the outliers here are 18, 19, 20%. I don't know what counties those are. The paper doesn't go into detail, but these are the outliers. So the average is around, what, 6 to 7%. That's, by any other measure in medicine, something with a 90% mortality rate is, you know, gets your attention, right? And this is cardiac arrest. This is something that happens every single day, pretty much in our emergency department. And it's, people don't really realize, even as a physician, just out of residency, I didn't really realize how dismal these outcomes were until I started doing more research. So just to give you some perspective, this little area of the Twin Cities is actually kind of a hotbed, right, of resuscitation, and our outcomes are better than the national average. And they're still pretty poor, I would say. So this is our data from Henderson EMS. Allina EMS, which is, of course, associated with Abbott, has pretty similar data, and we're all friends, so it's okay to share. Our overall survival last year was 14%, or 2017 now. They're still finalizing 2018 data. 14%, and so that's probably one of the higher rates in the country. Are if you take all the positive prognostic indicators, so shockable, witness, bystander, CPR, we're about 47% survival, and then compared to here's Minnesota and national average. But the national average of survival of good brain function after cardiac arrest is about 8%. So this is why we need to improve our rates, our rates of survival. We need to improve our resuscitation, right? This is a huge problem. And plus, we're working with a limited timeline. So this is data from, it's known as the Rescue trial. So this is a trial that was published in the Lancet in, I believe, 2010, 2011, comparing active compression, decompression CPR with an impedance threshold device compared to standard CPR. And so on the left are two curves. One's comparing standard CPR, or so one is for standard CPR, the top is ACD, ICD CPR. And then the right is just split out by rhythm, not by CPR method. And you can see there's definitely, so this is rate of neurologically intact survival, and the ACD rate increases at a higher rate than standard, but both of them level off just after 20 minutes. We see the same trend over here on the right, regardless of presenting rhythm. And so this is something that we're preparing for publication. I presented it at Emergency Medicine Conference. My colleague Guillaume Dibate presented it at AHA last year. And so we're working with a limited timeline, right? So we're looking at maybe getting someone on eCPR, ECMO for cardiac arrest. We know those patients do pretty well, can do pretty well if we get them on within 60 minutes. But this would tell us perhaps they need to be, pre-hospital, we need to be transporting by 15 to 20 minutes in order to get them on that ECMO within 60 minutes. So we're working on a limited time frame. And, you know, I propose that there is no silver bullet for cardiac arrest. As we've seen, there's no single fix, right, to improve outcomes. You can have a VFib presenting rhythm, which we know is a good prognostic indicator, but you can collapse in the bathroom and no one will find you for an hour, and then, you know, you're going to probably die, right? So we have to have a good chain of survival. Ideally, you'd want to collapse in this room with a bunch of highly trained people, close AED, close to an emergency department that's capable of doing ECMO, immediate bystander CPR. There's not one thing that's going to save somebody. It's everything has to go right, which is why this makes it so tricky. And then, again, it's not only restarting the heart, but preserving the brain too, right? So our task is pretty daunting. So enhancing perfusion during CPR is optimal for all brains and hearts, regardless of the etiology of arrest. And this is why head-up CPR is pretty exciting because, you know, I'm not sure how many arrests you guys see, but we see a lot of drug-related overdoses. And usually once you can get Narcan circulated and those patients get some rounds of ACLS and then they come back, but at what cost to their brain? And so if we can enhance CPR while that's happening, you know, I think there's increased chance that we can save those types of patients. So it's not just for our VFib cardiac etiology patients. So the inspiration for head-up CPR came from my mentor, Keith Lurie. He was in South Korea visiting his daughter, and his Korean cardiology colleague said, "Hey Keith, we need your opinion about something." So in South Korea, there's these very tall apartment buildings, I guess. I've not been there. But anyone who lives on the 10th floor or above has a way higher or way lower rate of survival than living at the 10th floor or below. And so they're asking him in 2013, I think, or 2014, what's the best way to transport these patients? So in the elevators, they're very narrow and people cannot be transported supine or flat. The two options are head up or head down. And so they were saying, let's do it. We were going to think about doing the head down, and Keith said, I don't think that's best. I don't know. My instinct tells me that's not right. So this kind of led into our first animal study. So how does this even work? So if we have someone who has a potential neurosurgical emergency, like I had a pediatric trauma patient yesterday who had a probably brain injury. So what do we want to do? We want to try to sit them up, right? It's a basic tenet of emergency medicine. And so what we're doing with that is there's a lot of venous drainage in the head, the paracervical plexus, venous sinuses, not just in the brain itself. And so when we sit somebody up, we're employing gravity to decrease venous drainage, decrease intercerebral pressure, and then you're creating space for forward flow. So when someone has a beating heart, that's optimal, right? But when you're in cardiac arrest, you have to be the beating heart for that person in order to take advantage of gravity in that situation. So we really have to have a good driver to pump blood uphill. But once we can do that, then we can employ the secondary effective gravity there. We also believe that head-up CPR decreases a concussion with every compression. So every time you compress someone's chest, the force of that compression is transmitted both up the arterial and venous vasculature to the brain, and you can just think about your brain kind of pounding on the inside of the table of your skull. Not a good picture. We've proven that it improves cerebral blood flow in pigs and perfusion pressures in pigs and human cadavers. We've seen trends toward improved cardiac flow. We're not really sure even what's happening in the lungs. That's a whole other kind of ball of wax we haven't been able to get really delve into yet. And then ultimately, we're hoping that it's going to improve neuro outcomes. Not sure that it's going to improve ROSC rates, but neuro outcomes is kind of where we're thinking this is going to have the most benefit. So the first study was done in 2014, and it was very simple. This is a schematic of a mannequin, but it was pigs laying on their back. And so they had a Lucas 2 CPR machine with an impedance threshold device. And so just a small number of pigs, 14, they underwent this protocol where they were flat, head up, and head down after a short duration of VF, and then measured different angles of CPR, brain blood flow, just to kind of get an idea of, is head up better, head down better, what's happening here. So this is the first of several schematics that I'll go through here in this study. So the front one, first one is our flat kind of reference slide here, and then we have our head up and head down. So you can see the aortic pressure with Lucas and ICD is pretty well maintained across all the groups. The RA pressure is pretty well maintained across all the groups. And here is where it gets interesting. So these are all molar catheters that are inserted into the animals, and we measure hemodynamics real time during resuscitation. So this pink line is our ICP. So here's our reference value. Look what happens when we go head up. It decreases, and the actual amplitude is attenuated. So I'm getting at that concussion with every compression effect is mitigated there. And then with the head down, you can see the amplitude increased, and then the ICP is over 60 here at the systolic peak. Our cerebral perfusion pressure, which is, of course, a calculation, mean arterial pressure minus ICP. Here's our baseline. It increases with head up. All right, there we go. And then decreases with head down. And so just to hammer this point home, if you take anything away from this, this is kind of the main physiologic message here. So this is what happens head down. This is your aortic pressure. So this is just real time here, and then the intervention happens right here in the middle. Aortic pressure is maintained, ICP rises, cerebral perfusion pressure falls. Head up, aortic pressure is maintained, ICP falls, cerebral perfusion pressure increases. So in that first study, cerebral brain blood flow was 50% higher. So that was significant. Cerebral perfusion pressure was also higher. Coronary perfusion pressures were also higher. So this was pretty fascinating work, and so we delved into a second study. So in that first study, the entire animal was tilted up on a tilt table. And so the second study, we refined it to just elevate the head and shoulders of the animal. Pigs don't really have shoulders, but you can get the analogy. And so this is, I'm not allowed to show actual pictures, so this is a very zen-looking pig undergoing CPR. And we just elevated the head and shoulders of the animal because we want to avoid that pooling effect that we think is probably happening when you elevate the entire animal. Eventually, over time, blood's going to pool in the lower extremities. It's going to be difficult to get it back up regardless of what method of CPR you're doing. In the second study, we compared different CPR methods, ACD, ICD. So our lab, we're firmly behind that method, and that's what's used by Minneapolis Fire in our emergency department as well. And then we switched to Lucas after. So for Minneapolis Fire, they do ACD, ICD for 15 minutes, and then they switch to Lucas for transport or after 15 minutes. Standard CPR is what's employed traditionally, of course, throughout the country, so we compared both. We did a longer VF time in the second study, and then we also did a concept of 2 minutes of flat, or we call it priming the cerebral cardio circuit. So we don't want to just sit the animal up abruptly or the person up abruptly and then causing all that blood volume to just pool, and it's going to be very difficult to get things started to pump uphill. Yeah?
I'm really sorry, stupid question. What is ACD compared to that?
Yeah, no, great question. Okay, so has anyone heard of active compression, decompression CPR? Yeah. Okay. No, this is good. This is great. So active compression, decompression CPR. So we'll do a little history lesson. My mentor, Keith Lurie, invented this device combination. So what happened was in 1990, when he was a junior EP fellow, he met a patient who had been resuscitated, I think, 3 times after a cardiac arrest by his family using a toilet plunger, to the point where actually this patient arrested his son, started doing CPR on him, and he goes, oh yeah, mom did the toilet plunger last time, and it was great. So he ran upstairs, got the toilet plunger, did CPR on his dad, got him back. And so Keith is meeting them in the hospital, and the guy says, hey, you should have one of these at the foot of every bed. So Keith was like, what the heck, this is really weird. Why does this work? So he started thinking about it, and he made a lot of trips to the hardware store to the point where the guy selling toilet plungers was like, what are you doing with all these toilet plungers? So the active decompression is the important thing here. So the Lucas machine decompresses the chest with 3 to 5 pounds of force, the active recoil. And so when you're decompressing with active compression decompression, you're pulling up on the chest with about 22 pounds of force. So there's a big difference. You're increasing negative intrathoracic pressure when you do that. You're creating a vacuum in the chest. You can think about it like that. And the impedance threshold device works as a one-way valve. So, I don't love physics, right? But this is basic physics. So nature doesn't like a vacuum. So if you're creating a vacuum in a chest, air wants to rush in to equalize that. If you just put your finger at the end of the endotracheal tube or your airway, it's going to prevent that from going in, and you're going to enhance that vacuum in the chest when you do that. So that's what the impedance threshold device does. It creates a vacuum. So that device combination together generates negative intrathoracic pressure, increases venous return, because a lot of the fluid in the system, the closed loop system of your body, wants to return to that chest to equalize that pressure. And so that's the concept behind that. That's an excellent question. So in the Lancet trial that I was talking about, comparing ACD compared to standard CPR resulted in an absolute survival and neurologic survival benefit compared to standard CPR. And that device combination then entered the FDA and got hung up there for about 5 years. Everybody forgot about it. So Lucas kind of had a triumphant arrival on the scene in the meantime, and everybody looks at the suction cup and thinks, oh, they're equivalent, but they're not quite. They're a little different. So that's excellent question there.
Why did I switch them?
Yeah, so when we look at the rescue trial, which is the trial that compared those two, the majority of survivors were within the first 15 minutes. There's just a greater absolute number. And so we're weighing the benefit of what's safe to do in the ambulance. you know, we know that mechanical CPR hasn't been proven to improve outcomes, right? Although we all like the Lucas machine a lot, I do too. Makes my life a whole lot easier in the emergency department when I'm running a code. But ACD is a manual device, and so you have to weigh what's practical with evidence, as we often do in clinical practice. Okay, so our second study, we did our priming, our flat, and then we also did a longer CPR time, about 22 minutes. And so actually, sorry, I don't know what happened to my results from that. So this is what I was talking about. Our slide here is the main outcome from that study. We showed increased cerebral perfusion pressure in the head-up group with ACD-ICD compared to the supine group, and then even better than the conventional CPR. In our third study, so cerebral perfusion pressure is a great outcome, but it is a calculation, right? It's not brain blood flow. So we wanted to try to replicate what we just saw in that second study with microspheres, which is a marker of brain blood flow. They're pretty expensive, and we didn't want to do it without some type of hemodynamic confirmation, so that's why we didn't do it the first time around. And we were able to show that brain blood flow, again, is doubled with the head-up combination with ACD-ICD. And if we look at this diagram, it's pretty busy, and I apologize about that, but let's break it down. So we have different regions of the brain, right hemisphere, left hemisphere, brain stem. These are our baseline values, which is why they're so much higher. And then we have minute 5 of resuscitation, minute 15 of resuscitation. Our blue line is the head up. And so the interesting thing about this is you can see minute 15, the blue lines are very similar. They're statistically equivalent to the ones at minute 5, whereas the supine values are decreasing. And so this is kind of traditionally what we see with supine standard CPR or even ACD-ICD CPR is the values just go down over time. With head up, we can preserve our hemodynamics over a greater period of time. And then just to emphasize, with our ACD, we saw higher flows, absolute number of flows, versus our first study where it was just over 5 minutes of CPR. The Lucas and ICD combination, the absolute numbers were like 0.2 versus 0.3, and this is 0.2 versus 0.4. It's a little bit different there. And then we're starting to get into the weeds here and say, okay, is there an optimal angle? We've been doing 30 degrees this whole time. So just this past year, we kind of delved into this a little bit more. We randomized animals to different angle combinations with the idea that if we randomize an animal to, like, if you got 30 degrees at the front sometimes in the middle, sometimes at the end, we could use each animal as their own control and look at cerebral perfusion pressures with smaller number of animals. So we're trying to decrease kind of our costs. And we hit upon this really interesting finding. So we didn't find a difference in cerebral perfusion pressure among angles. I mean, there's kind of a trend here. 20 degrees, the average across all these combinations was 36 millimeters of mercury versus 44 in 40 degrees. But we did find a sequence effect, which we'll talk about in a second. When you're talking about what angle or what height is best, we have to balance the idea of intracranial pressure, decreasing intracranial pressure with maintaining aortic pressure. And then just with this first study, we could see that as you increase your CPR angle, this is 50 degrees, you can see what happens to your aortic pressure over time. Whereas your intracranial pressure, you keep getting that benefit. At 50 degrees, it's negative, but then you have to balance that with decreasing aortic pressure there. So this is something that we're kind of at a balance with. Going back to our angle study, we looked at all our animals, and we saw that the cerebral perfusion pressure was much higher if 40 degrees was performed during the last 5 minutes of the resuscitation versus if it was performed like in the beginning. So you can look at here, 15 minutes of resuscitation, look at the cerebral perfusion pressure at 40 degrees, and look at the coronary perfusion pressure. If it's performed during the last part of the resuscitation, the average cerebral perfusion pressure was 80, almost normal, versus 20 and 30 degrees combined. So this led to we call it our sequence study. I presented this at ASA this past year. So we randomized animals to a 20, 30, 40 degree sequence. So we did 5 minutes at 20 degrees, 5 minutes at 30, 5 minutes at 40 versus a 40, 30, 20 sequence. And then we were able to show that our cerebral perfusion pressures were much higher with the 20, 30, 40 degree sequence versus the reverse. And these are I think our graphs illustrate this a lot better than the numbers. So look at our cerebral perfusion pressure. So the top line, the orange one, is the 20, 30, 40 degrees, and it's increasing. Again, we see this rise in cerebral perfusion pressure 15 minutes into resuscitation, which is awesome. I mean, this is not happening when we do a human resuscitation, the cardiac arrest rate. At 15 minutes, you're like, oh man, I don't know if I can get this person back. This is amazing. So then the green line is the 40, 30, 20, and so you can see it's kind of just leveled off at a much lower cerebral perfusion pressure. Coronary perfusion pressure trends towards the increase as well. And that cerebral perfusion pressure is really driven by that mean aortic pressure. We're able to drive it, maintain it, and drive it up as we gradually raise the animal up over time. And then our intracranial pressure, we continue to see that trend. The higher we raise the animal, the lower the intracranial pressure goes. And so then this is a current study right now. We're talking about how fast should we raise the head? Should we do it really fast? Or should we do it over 10 minutes? So we're studying these different times and looking at our cerebral perfusion pressures over time. So probably not 10 minutes, that's the lowest there. And so the best kind of outcomes that we're seeing is with 2 minutes. 4 minutes, 2 and 4 minutes are kind of statistically equivalent, and then our immediate rise, just over 24 seconds, doesn't perform quite as well. So we're ultimately recommending, you want to kind of create a pressure head, so to speak, with the animal flat or the person flat, and then you're gradually raising them over time to maintain that. So then I get so many emails about people who say, oh, I want to do this head-up CPR thing. You can do it wrong, we think. It's not done in people widely, of course, but we do think you can do this wrong. So the ITD seems like the bare minimum here to improve hemodynamics during CPR. When we've done standard CPR, we haven't been able to generate a good enough aortic pressure to reap that secondary benefit of gravity. We looked at coronary perfusion pressure in that first study, looking at the Lucas only without the ITD, and we were showing significantly decreased values of coronary and cerebral perfusion pressure in the head-up position compared to Lucas plus ITD. And then to hammer this point home, this upper right graph is a group out of Austria that in their primary outcome for a head-up CPR, they compared head-up CPR to flat CPR, and I think their primary outcomes were something like markers of cerebral metabolism, something that was fairly complex, and they did not observe a difference. And so they concluded that they didn't find a difference with head-up CPR on cerebral metabolism. And so we countered with, look how poor your cerebral perfusion pressure was. We wrote a letter to the editor for Resuscitation pointing this out. So if you look at cerebral perfusion pressure in that animal group, their top cerebral perfusion pressure with head-up was under 10 millimeters of mercury. I mean, nobody's going to survive that, even if you're a pig or a person. Versus when we did it, we actually had similar values with head-up conventional. We were about 10 millimeters of mercury. And so first you have to do high-quality CPR. First you have to generate good blood pressure during CPR. Then you can do, I call this like the third, fourth, sixth gear. You've got to have your basics down before you can do something more advanced like head-up CPR. Yeah, so we believe that you have to do head-up CPR with a circulatory adjunct, such as Lucas ITD, standard CPR plus an ITD, ACD, ITD. We did some head-up human cadaver studies because, of course, pigs are not people. human cadavers are dead people. So I think you can be a little dead and a lot dead, right? So when you're in VF, you're a little dead, and when you're a human cadaver, when you've been declared dead, you are really dead. So what we did was we went to the University of Minnesota with the Anatomy Bequest program, and we studied 9 recently deceased human cadavers who had donated their bodies to science. These bodies were never frozen. They were perfused by the anatomist there. And so the bodies had actual fluid in the cardiovascular system. And so we did 2-minute epics of standard ACD, ICD, CPR, and ACD, ICD, head-up CPR. And again, we were able to demonstrate, so we didn't do markers of flow in that study because that's impossible. But we were able, again, to demonstrate a decreased intracranial pressure with the cadavers with head-up position in an improved cerebral perfusion pressure. And this is a tracing from one of those studies. You can see here our aortic blood pressures here, which arguably the diastolic is, there's no, cadaver does not have a diastolic blood pressure at all. So we're just kind of more interested in our peak systolic values that we can reproduce there. But looking at our ICP, that's a real tracing that decreases with the head-up position. And our cerebral perfusion pressure down here increases. Coronary perfusion pressure is kind of irrelevant here. This was published in Resuscitation last year. Any questions? I went a little fast because we started a little late. A lot of physiology that we covered. So it's pretty cool stuff, but it's hard to follow sometimes. So based on that, oh, yes, sir. Yeah.
Oh, yeah. Hey, just one really quick question.
Yeah.
On the IPP,
Yeah.
what I just didn't understand about that is that if you have a patient who has return of circulation and respiration,
Yeah.
it seems like the way that device works is it inhibits you from kind of sucking in. So how does that go when somebody actually survives resuscitation?
Yeah, so it's a great question. So the ITD is a one-way valve. So you can, if you take a deep enough breath, inspiratory breath on it, so the current one now is called the ITD-16. If you can generate a negative anastomotic pressure of 16 millimeters of mercury, if you take a deep breath in, you can crack that valve and breathe. We don't recommend it for patients who have ROSC. So you take that valve off once someone has ROSC and has a spontaneous respiratory effort. Gasping doesn't. So gasping is a noted thing that happens during cardiac arrest, a positive prognostic indicator of survival, but we don't take that into account with the ITD. There is a newer device that's coming onto the market called active intrathoracic pressure regulation therapy, or active IPR. The trade name for it is called the CircuPod, which I think sounds like a crustacean or something. That is a device which is, I call it the ITD on steroids, where someone has to be endotracheally intubated and paralyzed, really. And that creates generates a continuous negative intrathoracic pressure to improve preload, and generally used in patients who have hypotension, brain injury, those kind of conditions. Does that answer your question? Okay. So based on that first PIG study, some very innovative people out there in EMS who, the front lines are watching people die on a routine basis, and they said, hey, what do we have to lose? We're just going to go ahead and do this. So on the left is what they do in Palm Beach County, Florida. That's where Donald Trump is from. Just a point of interest there. And so this person is elevated on a Pelican case. He's alive. He would have he looks serene. Don't worry, he's alive. So he should have an airway with an ITD on there, and then he has a Lucas device there. And then Rialto County, and I think this is a suburb of LA. They're kind of like in the Inland Empire kind of area. They use the autopulse. And then they use the ITD as well, and they started head-up CPR, and both of these systems are seeing improved rates of survival to hospital admission. So we just had a paper accepted by Critical Care Medicine a couple of weeks ago, and so describing our preliminary experience with Palm Beach County. So in 2015, so the intervention here was not head-up CPR. The intervention was a new EMS medical director. Okay, so this is why we can't give kudos all the head-up CPR. But so this guy Ken Shepke, he's awesome. He took over in 2015, and so he did a lot of stuff. He retrained his crews with pit crew CPR, so how to get someone on and off the Lucas real fast. He did passive oxygenation, so apply oxygen at a high rate but defer ventilation for 6 minutes, apply an ITD, do automated CPR with the Lucas device, and then raise the backboard up 30 degrees as you just saw. So a lot of things are changed there, right? This is our paper, which just got accepted. So outcomes, to see what happened before and after. Oops, totally spilled that water everywhere. So our outcomes here, 18% over survival to hospital admission before, 34% after. Not surprisingly, increased rates of survival for VFDT from 23 to 44%, and the non-VF, not in VT, lower. So pretty cool stuff. Got me a paper towel. Thanks. Okay. All right, and then this is a graph again showing kind of those increased rates of admission. You can see 2014 before Ken took over, much lower rates of survival to hospital admission than in 2016. Thank you. Looks like my backyard up here. So how are we going to do this clinically? Do you guys know this person? Yeah. This is, yeah, Dr. Minneapolis needs some resuscitation. He probably just needs some sleep, really. So, you know, I'm county, right? We don't have a lot of money. I'm like, convince me why you need a device, right? My mentor, Keith, of course, is the king of devices, and he's like, oh, we need a device. And I was like, I don't know. I'm not so sure about that. Because, of course, when you make a device and you charge for it, then you're not leveling the playing field, right? So, again, we started with just, okay, maybe we can just do this with a wedge and maybe a towel behind the head. We found that people slide off this, and it moves. It's really not, if you try to do CPR on someone like that, they're just going to fall right off or slide to the bottom. So we switched to this. Maybe we can do this. We can add the sniffing position with a head tilt right here. You can cut out the head there and have them have their head back, so that would be optimal for intubation, perhaps, or airway management. And then you kind of just slide down. That's Keith there. Doing okay. He's doing okay. So this is our latest. I shouldn't say our, because I helped develop this device, but I don't have a financial interest in it, other than academic. So this is a device that fits in with the Lucas, and so this is deployed head up, but when it's flat, you can hook in the Lucas. The patient's kind of locked in place, and then as you elevate, the Lucas does not migrate or move on the chest. So in the emergency department, I've done this I've done head up CPR on a fair number of people now, just because of the dire nature of their resuscitation. You know, it's kind of like, what do you have to lose? In my clinical opinion, I think this patient, you know, we'll give it a try. We'll see what happens. I can't get them to a full 30 degrees. The Lucas starts to wildly kind of tilt back and forth, just, you know, raising the bed up just on a regular hospital gurney. It starts to rock back and forth. Someone has to hold it, or it starts migrating down the chest. So you have to keep an eye on it. So I've tried to do these things. I have concluded that I think a device is probably the best way to implement this in the pre-hospital system. And it's a way to make sure people are doing this consistently and reliably correct, the way that it was studied. I have a concern that people are going to go out into the world and try to do it with this or this, and it's not going to be performed correctly, and then the patients are not going to do well, and people are going to conclude, oh, this doesn't work, you know. But but you have to make sure you do it well, right? It's like any CPR trial. We have all these negative CPR trials, and you go back and look and see how many people actually got really good CPR. Like 40% of them did. So why are you going to see a benefit, right, with whatever you're studying if you can't even ensure that the majority of your patients get good CPR? So this is from our paper or our letter to the editor to Resuscitation. We have proposed do's and don'ts of head-up CPR. So the do's, use circulatory adjuncts during CPR. So either the ITD alone with standard CPR, automated CPR with the ITD. And we found that any automated CPR device is able to generate, consistent hemodynamics with the ITD, with the mean arterial pressure to generate a good mean arterial pressure to reap the secondary effect of ICP, and then ACD-ICD. We do recommend priming the circuit before elevation at least 90 seconds, where the person or the pig is flat. You do CPR flat, and then you gradually raise the head over time. Elevate the head and shoulders only during CPR to mitigate that blood pooling in the extremities effect. So we haven't specifically studied that in our lab. Our Korean colleagues kind of did us a service by inadvertently doing that. A couple of years ago, they their plans were to do an animal survival study where they randomized people or pigs to flat or head up position. And so after VF, they raised the animal to I think like 30 or 45 degrees just abruptly, and then did CPR either in that position or flat. The animals that were at the head-up position had great ICPs, and that they were very low, but then they were unable to obtain ROSC on any of those pigs. So if you can't get ROSC, what good is a negative intracranial pressure? So we think that it's very important to prime that circuit and slowly elevate, over a period of like 2 minutes, 4 minutes. So do not perform head-up CPR with standard CPR alone, because your mean arterial pressures during standard CPR are very poor. Don't raise the head immediately when arrest. Try to avoid elevating the whole body. And then don't just elevate really high and then say, okay, they're head up, that's good enough. I call it kind of Goldilocks resuscitation. You can do it just right. You can't do too much, can't do too little, and do just right. So is there any questions about that at all? And then ultimately, how does this fit into the bundle of care? We have proposed kind of, not areas, epics of cardiac arrest, or phases, I should say, by Myron Weisfeld years ago. So the electrical, circulatory, metabolic phases. And so as an arrest goes through time, the physiology is changing, the patient's becoming more dead, and there are things that are more or less likely to work. Head-up CPR fits into most of these categories. And then ultimately, I think this is kind of where this is really, this circulatory and metabolic phase is really interesting, because we're extending the metabolic phase by doing eCPR. And we're showing that the circulatory phase, with those first graphs that I showed you, maybe is extending up to like 20 minutes, really. That's kind of what we're proposing in our new paper. So this is changing, and the therapies in it, there's multiple ones here. So I've resuscitated people in refractory VF, not with eCPR a couple of years ago, with like, esmolol drips, and, we do amiodarone, lidocaine, esmolol, double defibrillation, these kinds of things. So there are lots of options, but again, our outcomes are pretty poor. Good, so summary, head-up CPR is improved. Hopefully I've proved to you that it improves cerebral perfusion with circulatory adjuncts. It's a lesser degree cardiac perfusion. We've been able to replicate our animal study findings preliminary in a human cadaver model, and we've shown at least that it's not harmful in people. It's used successfully in parts of the country with improved rates of survival to hospital admission as part of bundle of care. And ultimately, it's a promising therapy to improve neurologic outcomes after cardiac arrest, probably not ROSC, but neuro outcomes. So again, there isn't a silver bullet. This is one promising therapy out of many that everything needs to go right. to save these patients. But we're in an exciting time. Things are changing. Pretty cool. Yeah, so that's all I got. I have references here, 3 slides of them. Happy to send those to anybody, and I'll take any questions. Yes.
Thanks for an excellent talk. I understand how the head-up CPR improves cerebral perfusion. I'm a little bit less clear on the mechanism of how it has a slight improvement in coronary perfusion, though. Does your group have any thoughts about how that is happening exactly? Or
yeah, we don't know. Ultimately, we've seen slightly improved coronary blood flow. It's always, the cerebral blood flow is always significant, and the coronary blood flow is always almost significant. The perfusion pressures are usually higher and usually significant, but the blood flows trend that way. So I don't know if it's just that we're really increasing preload to the heart and increasing flow, but there's also a relationship with the lungs too, I think, that we don't fully understand. So I think that might have to do something with our cardiopulmonary kind of relationship there. With the lungs, we've been thinking about kind of the west zones of the lungs, and if you think about someone right before they arrest, or like a heart failure patient and they're in respiratory stress, what they want to do is sit up. You know, no one wants to lay flat. Like right before I have see someone arrest, or I intubate a COPD or something like that, or asthma patient, they're sitting bolt upright, right? They're trying to breathe at 1 million times a minute. And so we're kind of replicating that position with head-up CPR, especially if someone has a lot of congestion in their lungs or pulmonary edema. You can imagine you're creating a shunt where you're hopefully creating preferential flow to the upper lobes of the lung. And so this is all kind of theoretical stuff that we don't really know yet. Yeah, so anyway, I think there's probably a relationship there, and I think there's improved cardiac blood flow to a degree with the elevation, but we haven't been able to prove that. Yeah.
I don't know if you showed it on your slides, but did you guys have a measurement of the right atrial pressure with the head-up CPR?
Mm-hmm. Yeah.
And what does that how does that change?
Yeah, in general, it's decreased.
Decreased.
Mm-hmm.
Right atrial pressure.
Mm-hmm.
So that's why coronary perfusion is better, I think, because the coronary sinus has better drainage. That would be my guess. You know.
Yeah, I think we're improving flow on the right side, yeah. On both sides, really. Trying to find. I can try to find it later. I'm not finding my RI pressures here. Yeah.
Yeah, great talk. Thank you so much for coming. So my question is, do you have any clinical data for the group of patients from Florida that they demonstrated that it was higher cerebral perfusion? Like what was their, CPC at 30 days or 6 months? Do they have any of that data?
So Florida, they don't have like a cohesive central database like we do with CARES for CPC scores. They just did this. They just implemented CARES, I think, at the beginning of this year. So they didn't have an organized system for measuring this. So they don't have that data yet, but I know they're working on it. This brings up an important point of how do we know this. So as we're proposing to deploy this device, and so Alina. So hopefully later this year, part of the Alina service area in Anoka County and then St. Paul are going to be the first areas in the country to use this device. And so you can think about, we're doing this in a limited patient population, and we're not going to look at survival right away. Kind of too grandiose to think that we're going to see an improvement in survival. So then the question is, we can't put an ICP bolt in these patients, right? In the bathroom floor or something. So we're looking at things like signs of perfusion. So if patients are gasping, if they have pupillary response, if they move during CPR or talk. Last year, so when we implemented ACD, ICD, CPR into the Minneapolis Fire Department, I started asking the firefighters to collect signs of life on the scene for me. So they check a little box, yes gasping, yes moving, yes talking. And so it turns out if anyone has gasping movement or talking. All 5 patients who were moving or talking during CPR walked out of the hospital. And the odds ratio should remain elevated for all those signs of life. Improved color, you can feel a pulse during CPR. So these are things that we're going to be looking at clinically. It's because we can't measure cerebral perfusion pressure in people until they're in a neuro ICU, right? So this is, yeah, a lot of these people aren't going to survive to make it there.
Okay, well, thank you very much, Dr. Moore.